Hello, my name is Dr. Moore. I am from the California Center for Reproductive Health and the Center for Tubal Reversal. And I'm here to speak to you today about tubal reversal, otherwise known as tubal reanastomosis. The procedure is a procedure that's offered to women who have tied their tubes previously after they had completed childbearing, but then for one reason or another decided that they want to have another child. Options that exist for patients who have had a tubal ligation are to reverse the tubal ligation. That's why we call it a tubal reanastomosis or a tubal reversal, or in vitro fertilization. And I'll touch a lot about tubal reversal and a little bit about in vitro fertilization. So let me address some of the frequently asked questions for women who are curious about tubal reversal procedures. One question we get quite often is that, "Doc, my tubes were burned. Can you reverse that?" Well, burning of the tube, quote unquote, is a procedure commonly done during some types of tubal ligation procedures, and that involves cutting part of the tube and burning the tips. Most of the times, a physician will cut and burn a small part of the fallopian tube, typically under 3 centimeters. And most of the times, the physician performing the tubal ligation will cut and burn the middle part of the tube. That makes the vast majority of cut and burn tubal ligations reversible. If enough of a proximal part of the tube exists still up to the burnt area, and enough of a distal part of the tube exists beyond the burnt area, those two ends of the tubes can be placed back together for a final tubal length, which will be shorter than the original tube, but provided it's beyond a certain threshold length, should be reversible and should be able to achieve pregnancy at very good rates. The final length of tube is one parameter we use to dictate the success rates of a tubal ligation. Patients often will wonder, how do I know if my tubes are reversible? Well, one way of determining that would be to obtain the operative report and or pathology report of the original tubal ligation surgery. In the original tubal ligation surgery, the physician performing the procedure will dictate exactly what part of the tube and what length or portion of the tube was intentionally damaged to achieve a tubal ligation. When we review this type of report, we can determine with pretty good certainty whether or not the tubal ligation is reversible. In some cases, the operative report will clearly determine that a tubal ligation is not reversible, and the patient would be a candidate for in vitro fertilization rather than a tubal reversal. Whereas in most cases, an operative report will confirm that a tubal ligation is reversible, and we can predict with pretty good accuracy what the final length of tube will be and what the patient's odds of success for pregnancy would be after a reversal. If the operative report of the tubal ligation is unavailable, but the pathology report is available, and a pathology report would be available in the event that a portion of the tube is removed. Some tubal ligation procedures involve clipping of the tube or placement of a rubber band on the tube, and in that case, there is no removal of actual tubal tissue, and no pathology report will be available. In many cases, a standard tubal ligation will involve removal of the middle part of the tube, in which case that part of the tube removed from the patient's body is sent for pathology, and the pathologist will then determine in a pathological report what the length of tube and part of the tube is that was removed. That gives me and our tubal reversal team a very good idea of whether or not the tubal ligation is reversible and what the final length of tube would predictably be. As we've discussed, some factors that determine success rate after a tubal reversal have to do with the length of tube remaining after a tubal reversal. Other factors include a woman's age, and of course, intuitively, one can understand that as a woman gets older, the success rates of pregnancy in general decline, and they do so as well after a tubal reversal. In younger patients, generally under the age of 35, success rates are very good. Over 2/3, up to 70% of patients may conceive in the first 1 year of trying after a tubal reversal. In older patients over the age of 35, success rates may diminish, and ovarian reserve testing may sometimes be necessary to determine how healthy a woman's ovaries are to accurately predict success rates after a tubal reversal. Success rates after in vitro fertilization, which is the alternative treatment to a tubal reversal, also diminish with age. Of course, other factors go into accounting for success rate after IVF as they do after a tubal reversal. But IVF success rates tend to mirror success rates of a tubal reversal with some differences. One difference between IVF and a tubal reversal is in vitro fertilization is a much costlier procedure, and the cost effectiveness of the treatment across all age groups is lower than a tubal reversal. That is to say that one would expect that the amount of money couples would have to spend to achieve a pregnancy with IVF will generally always be higher than the amount of money they would have to spend for a tubal reversal. Another factor that's different is the fact that one is a surgical procedure, as in a tubal reversal, which requires general anesthesia and observation, while IVF is, for the most part, a non-surgical approach to achieving pregnancy. A third factor that's different between the two procedures is that with a tubal reversal, there is an increased risk for a tubal pregnancy. On occasion, the embryo will get stuck in the fallopian tube at the site where the tubal reanastomosis procedure was done. The risk is about 10 to 15%. With in vitro fertilization, the risk for an ectopic pregnancy or a tubal pregnancy would be generally less than 3%. There is also a difference in multiple gestation rate. With a tubal reversal, the vast majority of pregnancies will be singleton pregnancies, whereas with IVF, on occasion, there may be a twin pregnancy. That really depends on the number of embryos a patient decides to have transferred back into her uterus in an IVF procedure. Many patients wonder exactly how a tubal reversal procedure is performed. Various techniques exist, including a laparoscopic robotic approach. However, for the most part, a mini laparotomy is the preferred approach. A mini laparotomy means a small mini incision in the lower abdomen, which is a side-to-side bikini line incision, typically about 2.5 to 3 inches wide. That mini incision also means that the recovery time from the procedure is quite fast because it's a small incision, and most patients are back on their feet within 24 hours, and they're able to resume semi-normal activities like household chores, driving within about 3 to 5 days of the procedure. Completely normal recovery is typically expected within 10 to 14 days of the surgery. Through that mini incision, the abdominal contents are accessed, including the uterus and tubes. During the procedure, we partially deliver the uterus and the adnexa, which are the fallopian tubes and the ovaries, out of the incision, the abdominal incision, so we can have better access to the tube and easy access to the tubes for the repair. The procedure itself is done under microscopic visualization. We typically use surgical loops that magnify the tubes so we can adequately visualize the fallopian tubes that are very small in caliber in various areas, making it much easier to reanastomose the tubes under microscopic visualization. The techniques used are microsurgical techniques. The tube is a very delicate organ, and microsurgery is required so that the tissue is handled with great care and without too much trauma. Not much desiccation or burning of the tube is done, and most of the procedure is done with an atraumatic approach to the tube to minimize the risk of bleeding, to minimize the risk of scar tissue formation, and to maximize success rates for the procedure. The procedure typically lasts about an hour and a half through the mini laparotomy approach. Recovery is fast, as mentioned earlier. The patient it goes home the same day, which means this is an outpatient procedure and recovery is done at home. A post-operative check is recommended typically within 3 to 5 days of the procedure to make sure the patient is recovering well. A question commonly asked is, how do you know if my fallopian tubes have been adequately reanastomosed or reversed? Well, during the tubal reversal procedure, a small instrument is placed into the patient's uterus that allows us to inject a blue-colored dye through the uterus and into the fallopian tubes to confirm that the reanastomosis procedure was successful. So the surgeon will not leave the operating room until the confirmation of a successful reanastomosis is made. That does not guarantee that the tube will remain open, but in the vast majority of times, if the tube is open at the time of surgery, it'll remain open for many months to come. If a patient does not conceive within 6 to 8 months of the procedure, we generally recommend that a special X-ray is performed called a hysterosalpingogram, or in short HSG, otherwise known as the dye test, is done with a radiologist to determine if the fallopian tubes are still open. If the fallopian tubes are still open, of course the recommendation is to continue trying naturally. If the fallopian tubes for one reason or another are blocked, then a discussion is done with the patient regarding alternative treatments such as in vitro fertilization mentioned earlier. A patient may be a candidate for in vitro fertilization also if a semen analysis shows that the semen is of poor quality, making the patient and their partner better candidates for IVF than they would be for tubal reversal, which relies for the most part on a normal semen analysis. As mentioned earlier, some tubal ligation techniques are not reversible, making the patient a better candidate for IVF. Of course, if a patient fails a tubal reversal, they become a better candidate for IVF. And if a woman's ovarian reserve is severely diminished and the time or the window of opportunity for pregnancy is reduced, that patient may want to weigh the options of an IVF treatment over a tubal reversal as a better means of achieving pregnancy. Thank you for the opportunity of sharing my knowledge about tubal reversals with you. For additional questions and answers, please log on to our website, which is filled with plenty of information about the procedure, preoperative care, postoperative care, and so on. Our link is below. We'll be happy to perform a consultation for you to make sure you're a good candidate for the procedure, and hopefully we can help you have another child.